Welcome everybody to the Independent Sage Friday briefing. Now, 2 years ago this week, the UK began a full nationwide lockdown in response to the growing threat from COVID-19, a novel virus that was sweeping across the globe at frightening speed. More than 20 million cases and 165,000 deaths later, and we're still not out of the pandemic in the UK. Recorded daily infection rates climbed above 100,000 earlier this week, although the real figure is likely to be much higher due to a fall-off in testing. And COVID-related hospital admissions are rising again, putting the NHS under increasing pressure. Despite these worrying trends, nationwide surveillance of COVID infections is ending next month. Access to free testing is ending next Friday. And the government's scientific advisory group in emergencies, SAGE, has been stood down. Even in a country where most of us are vaccinated, COVID is still causing significant morbidity and mortality, illness and death, more than any other infectious disease. And it's putting enormous strain on our health service. It's causing widespread school absences. It's still impacting on our children's education. And of course, it's also impacting the economy. It's clear that we need a long-term strategy, not only to deal with the impact of long COVID, but also to take measures to offset the pandemic's effect on health resources and to create a home and work environment conducive to this changed reality. This is going to be the focus of our discussion today. Before we get into that, I should note that some of our colleagues are absent again today as university strikes over pension cuts and other issues to do with university education. We all want to express our solidarity with those colleagues. To start us with a discussion, then I'm handing over to Professor Martin McKee. Martin.
Okay, well, thank you, Alice, and you will forgive me that my voice is slightly going because unfortunately I've managed to get COVID. But this is going to be your last session chairing us as a regular chair of Independent Sage. Now, you say at the end of every session that everybody gives their time freely to Independent Sage, and of course we do it because we believe that it is important to engage with the public, and especially those who have been on the front line and who have suffered so much. But one of the other things that keeps us going is the friendships that we have developed among ourselves and with so many amazing people, some of whom, some of you I did know before, and some of you whom I didn't. And if you will forgive me a purely personal note, as I think I may have mentioned to you before, many years ago, I was profiled for a journal and they ask you lots of personal questions. And one of the questions was, well, what do you watch on television? And I replied, essentially anything that has Alice Roberts or Lucy Worsley in it. So given all of that, I was absolutely amazed that I would end up appearing with you on a weekly basis on our small screen. But I want to step back from my own personal views to speak on behalf of us all and to say that we are incredibly grateful for everything that you have done for us. Chairing sessions like this is really not easy. Now, of course, you need presentational skills, and we all know that you've got that. We watch you on television and we recognize that. But the other thing is that you need to do your homework and to understand the topic. And although this is a really fast-moving field, which we're all struggling to keep up with, you've done that with remarkable skill and clear commitment. So essentially, thank you so much from all of us for everything that you have done for us, and we really will miss you, and I think all of our viewers will as well. Thank you so much.
Thank you very much, Martin. And it was a very hard decision, but I have got a lot of other commitments coming up. However, I hope that you will have me back at various times in the future. I hope that I can continue being a friend of Indie Sage, and I will make reappearances. Thank you.
And I think it's now over to Christina.
Right, some numbers just to cheer us all up for the weekend. Right, so today I'm going to go over prevalence, hospitalizations and deaths, just mention something about schools because we've had another update from the Department for Education, and just also something on behaviours where we've had a new update from ONS surveys. So prevalence is not a pretty picture. So this is the percent of the population testing positive for COVID in the each week. It goes up to the week ending the 19th of March. Remember, this is random testing. It does not depend on test-seeking behaviours, which is really important. And, you know, every nation is far, far higher than it's ever been. Northern Ireland is now coming down from its extremely high peak, but Scotland has set a new record for the whole pandemic that week, the most recent week, of 9% of people in Scotland have COVID. And that is just, I mean, I don't know quite how to get across just how insanely high that is. In England and Wales, it's about 6.5%. Wales is at a record. England is approaching its January record as well. In England, every single region has gone up a lot. I mean, everywhere is really high. It's still a bit higher in the south, but it is going up everywhere. And in every age group, again, we're seeing a really big surge in primary school. We're seeing new surges in secondary school, but actually in every age group, we're seeing it. And we're now seeing really high levels in the over 50s. And actually just looking at the over 50s over the whole pandemic now, this is all ONS survey data, you can just see how much higher Omicron has driven this than at any other point in the pandemic. Over 70s, this is up to the 19th of March. Over 70s are far, far higher than they've ever been. 50 to 69-year-olds are almost as high as they were in the first peak. And, you know, basically, thank God for vaccines. And we're seeing in Hong Kong just how terrible the consequences are in an under-vaccinated elderly population. But this is still incredibly high rates. And we are seeing this feeding through into hospitalizations. And unfortunately, we will see it feed through into deaths as well. We're already seeing another week of increases of outbreaks in care homes. And, you know, ONS data is pretty much our gold standard. It's our best way of knowing how much COVID there is around, but it is a little bit lagged. So that was the week up to the 19th of March. The King's College Tracker app is probably the most up-to-date, where people enter their symptoms every day. And this is still showing a really big increase. Every region in England is still going up. Every nation except Northern Ireland is still going up. And every age group is still going up from the Zoe app. So it's not quite clear when we're going to peak. I'm hoping it might be next week, because then we've had, you know, actually 2 weeks of really nice weather across the whole of the UK, which hopefully has driven people outside. And also many schools start breaking up for the Easter holidays. So that will take that out of the equation. And at some point, you're just going to run out of people to infect. So hopefully we will start to see numbers coming down, but this has just been an incredibly high wave. So looking at hospitals, this is the number of people in hospital per million people across the nations up to the 24th of March. You can see that Northern Ireland has peaked and is now coming down. Scotland, again, is really high. And actually, there are more people in Scotland now in hospital with COVID than at any point in the pandemic, including their alpha wave. Now, about half of those people won't be there directly because of COVID, but it's still a massive strain on hospitals. You still have a lot of infection control issues, and you still have people who are more vulnerable catching COVID. The number of people is also going steeply up in England and Wales. I already said that about Scotland. If we look at ICU, so intensive care in Scotland, there is a bit of positive news actually, in that the number of people needing mechanically ventilated beds, so who need help to breathe, is coming down in Scotland. So hopefully Scotland, which started its surge earlier this time, will be coming down soon, I hope. In England, admissions are still going up, so we're almost back at the peak that we saw in January. We've gone over 2,000 admissions a day. Infections are still going up. So Chris Whitty said this week that he expects hospital admissions to keep going up for a week or two yet. I think he's right. I don't know how far they're going to go, but certainly, as we'll see, it's not trivial. If you break it down by whether people are in hospital for COVID as their main diagnosis or for another reason as their main diagnosis, so COVID is red and other reason is blue, you can see that both are going up steeply. So yes, about half of people in hospital are not there directly because of COVID, but both numbers are going up, and that's a problem. Numbers are also going up in the over 65s and over 85s here. And again, this is partly because we're seeing really, really high prevalence in these ages, but it's also because most people in this age group had their boosters 4 to 6 months ago. And the latest report from UKHSA that came out yesterday actually now looks at vaccine efficacy by primary diagnosis. So it looks particularly at people who are in hospital directly because of COVID. And you can see that although vaccine efficacy is quite high after your booster, as you go from 2 weeks out to more than 100 days out, it does wane. So it goes from like 96% efficacy to 87% efficacy. Now, that may not sound like a big drop, but it's effectively kind of tripling the risk in this age group. So the spring booster program started on Monday. So I do urge people who are over 75 or otherwise clinically extremely vulnerable to go out and get their 4th dose. And we're also seeing an increased pressure on the NHS in terms of number of staff off. That is continuing to go up. Orange is people off because of COVID, and blue is other reasons. And you can see that these increases have been directly because of COVID. It's not other things, it is COVID that is causing these staff crunches. If we look at deaths, so this is number of deaths within 28 days of a test by date of death. So I only go up to 16th of March because it's quite a lagged indicator. You can quite clearly see the BA1 wave here. Now, at the moment, everything is flat, but we wouldn't really expect to see deaths from the current wave go up for a few days yet. And you see the same picture if you look at number of deaths with COVID on the death certificate from ONS registry data. This is up to the 11th of March. And again, you can see at the moment they're flat. But if we look at Scotland specifically, so basically you're zooming in on the dark blue here, you can see that we do now see a BA2 wave in deaths as well. And this goes up to the 18th of March. It's a little bit more recent than the other nations. On schools, so this is just looking at primary school and secondary school kids from the ONS infection survey data, and you can see that there has been a new wave here for primary school kids. It looks like it might be starting to level off, and it didn't quite reach the heights, but there's still almost 10% of primary school kids infected and almost 6% of secondary school kids infected. And we are seeing this now in school absences. So this is half term. And the Department for Education has now stopped reporting these numbers daily and just doing once a week. But you can see that since the beginning of March, the numbers of kids off school because of COVID has tripled. So it is certainly causing an issue. And more even than the kids being off is teachers being off. So we're back at almost peak staff absences of 9% of teachers being off sick, which is pretty bad. And they've also stopped breaking it down by reason. So we don't know how many of these are because of COVID or not. And then just finally on behaviours. So, I mean, just personally, as I look around and I can see all these people getting COVID, it doesn't seem like anything has changed. So in December, when Omicron first hit, people did change their behaviours. We were a lot more cautious. We did test more, we wore more masks and so on. But that isn't really happening now. So this is from the ONS survey. And this is the percentage of people who said they wore a face covering, who did social distancing, and who avoided physical contact. Now, this is the Omicron BA1 wave over Christmas. And you can see then people did change their behaviours to become more cautious. When that was over, that dropped, and it's continuing to drop. So actually people are not responding this time. I don't know whether it's that people just aren't worried anymore, or it's not in the news, or we're not seeing the government saying anything, but for whatever reason, our behaviours really are not following infections. And I think that's quite a new thing. And we're seeing the same with working from home. So this is the again, the December wave. And it's partly because there were Plan B measures in effect, so people were asked to work at home. But again, now we're seeing more people traveling to work and fewer people working from home. So just to summarize, the ONS survey, again, shows the number of people with COVID is rising in all nations except Northern Ireland. I should have written that in. The number of people in hospital is still increasing, again, except in Northern Ireland. Now, deaths are flat and likely to increase in the next few weeks for England and Wales, and they're already increasing in Scotland. Boosters are waning, especially in older populations. As I said, school children are another big wave with big increases in children and staff off school. And really, it's a good thing we're coming to the end of term for that reason. And despite being back at really peak numbers, people are reporting fewer protective behaviours, such as mask wearing and working from home. So I personally am limiting my social activity during this wave, and I'm being very careful about wearing masks and so on. And I kind of would I would urge people to consider doing the same, and I will end there.
Thank you very much indeed, Christina. And now I'm going to hand over to Professor Deenan Pillay, who's going to start us with the discussion. Deenan.
Thank you very much, Alice, and thank you, Christina. And Alice, just to add, take the opportunity of adding my immense thanks and gratitude to you for everything you've done to help us keep going during this prolonged period that's still with us. So thank you very much. So one of the characteristics of our Indie Sage sessions every Friday is dealing with the here and now. You know, what is happening, hearing the sort of quality of presentations of this form that Christina has just provided to us about the numbers, but also identifying specific areas for which we've written reports about advice as to what should happen now. And of course, for the general public, those of you listening in, seeking your views. But it is important as well to have a longer term view. Although there's been lots of talk of thinking to the future of building back better, there's very little discussion of that still now. And we are in the midst of a government policy which seems to be, let's get back to normal. Let us almost forget what we've been through. And this doesn't, of course, deflect from the need for all of us to regain social life, economic activity, and so forth. I don't want to diminish that, but nevertheless, it is important to think, what does learning to live with the virus actually mean as we move through 2022 and beyond? And so to push this forward, we produced a report which covers a range of aspects from policy, from social policy, through to NHS structure, through to public health, communications, vaccines, antivirals, how to make spaces safe. And this document is on the website, and we're putting it up early so that we can have time for you, the public, to feedback with ideas as constructive as possible, please, so that we can have this consultation period before finalizing the document. But to coincide with that, we thought we would spend the next maybe 15-20 minutes before we come to general questions with me putting the panel here on the spot with regard to what do they actually think about the future. And I'm asking, I'll be asking each of the panel these questions. And what I'd like to elicit as answers are maybe not the usual way that we address issues in terms of the here and now, but where do we see things going? What is needed to be put in place now for the next few months or the next year? And what would we be advising both the health service, policymakers, and so forth around this? So I'm going to do that, and I'm going to start in order to take advantage of Martin McKee's voice before it disappears, his COVID croak. And Martin, within the document, we touch on issues of future public policy, particularly about what, defining what has not been defined so far by government. What are the criteria used to elicit certain interventions to control this virus, but also to control other potential pandemics in the future? What, from your perspective, and particularly with your understanding of the European context, where do you think, what should be the government be discussing now? How would they organize themselves to develop that sort of policy agenda?
Well, this was something that we thought about a lot in the Pan-European Commission on Health and Sustainable Development. And in that, we make a strong argument for prioritizing health as a goal of societies for a whole series of reasons. I mean, first of all, it's the right thing to do, but a healthier population, it contributes to economic growth. Lots of evidence on that. Something that resonated a lot with my fellow commissioners was the evidence that people who are left behind in the health stakes tend to turn to populist politicians and to xenophobia and divisions. And we've seen the problems of that in a number of countries, particularly my colleagues in Eastern Europe were anxious about that, rather presciently so, as we know. So I think that argument that health is a measure of the progress of nations is, I think, a key thing to keep at the front. Now, in a way, we in the public health community shouldn't need to make that argument because there are plenty of other people doing it. I've said before, Mark Carney, former governor of the Bank of Canada and of England, wrote a book, Values, which is really making that case, a public health textbook. Gordon Brown's book, 7 Ways to Save the World, does the same. So a lot of politicians, but particularly in other countries or no longer in office here, have, and people in that sort of general sphere do get it. And then that says that as you're looking ahead, you put in place all the measures that will mean that if you do get another threat, and in the report we set out all of the threats that we could think of, which included everything from cyber attacks, organized crime, war, tragically, a new pandemic, and so on and so forth. Your society is prepared for that, and it looks holistically. As we wrote at the very beginning of the pandemic, when we said that we knew that there would have to be measures put in place to interrupt transmission, but they would have consequences, particularly for the poor and vulnerable, and we needed to think much more about them, which I don't think we did. So I think it would say that you take a holistic approach, which looks at not health or the economy, which I think is completely misguided, and see health as part of, health and the economy going together. And then lots of things flow from that. And, we shouldn't forget that way back in the old days, when, and I'm not getting into the party politics of this, the Wanless report, which made the argument for investing in the health of the British public, was convened by the Treasury, not by the Department of Health. So there are people who get it. And I think that we just need to make sure that those views are more clearly understood. They are in a number of other countries, and I think we can learn a lot from that.
Thank you. That's really useful, Martin. A great framing of the discussion. So that takes me. I mean, that's the holistic and the high level approach. But clearly, the health service itself is at the sort of sharp end. And I want to come to you, Helen, sitting in primary care within the health service. But of course, primary care is a critical component of the NHS, and indeed keeps overall costs down, because of course it becomes the filter between communities and expensive secondary care. But of course, primary care itself is going through major changes, and COVID has brought huge stresses in terms of new responsibilities for rolling out vaccines and so forth. Can you sort of think about, again, for the rest of the year, for instance, as primary care moves back towards face-to-face consultations, although you may want to comment on the longevity of virtual consultations. Can you sort of give some idea of where you think you'd like primary care to be moving in the context of the broader health service challenges?
Yes. So at the moment, the thing that's really troubling both primary healthcare and hospitals is staff absence, is sick staff. So we currently have more patients and fewer staff, which makes things really, really difficult. In primary care, we're doing reasonably well in terms of giving ourselves decent masks because we're responsible for looking after ourselves. But across the whole of the NHS, we just need to be doing the basics better to try and keep our staff here in terms of air quality, in terms of masks, in terms of testing. I mean, we don't know what's going to happen after the 1st of April because no provision has been made for us to check that we're well enough to come to work because free testing's ending. There's no mention of any supply for health workers. So there's kind of immediate problems that throw themselves up. General practice as a whole, there's been the whole question about how many of our patients we see face to face has been an issue even before COVID, because you may remember there was a health minister a little while ago who basically very keen on tech and we should be doing everything via video, except it doesn't really work. And actually not many people are using much video at all in primary care. It's either phone calls or it's face to face. And quite a lot of us have now gone back to a lot more face to face than we were at peak COVID, because it's difficult to do it really well over the phone. It's difficult to do it safely over the phone. But if you've got, as we saw in Scotland, if 9% of your population have COVID at any one time, that's an awful lot of people potentially walking into your room bringing COVID. So the kind of balance between keeping staff safe and doing the job properly is, and I think will continue to be, quite a problem. And if we don't keep our staff safe, then we don't have enough staff and we can't do the job properly. So we're really between a rock and a hard place with that. The thing that we really, really need is proper workforce planning, and the time we really, really need it is about 7 or 8 years ago. But we still need to get on and do proper workforce planning so that we have enough doctors to provide the service. And I suppose the other thing that I would add on that is that the workload is increasing. Just at the moment, there's a huge amount of acute COVID coming to us in primary care. Luckily, most of the people aren't massively unwell because they've been vaccinated, but some are. I'm also getting a lot of long COVID, and there's a kind of there's two things going on. There's long COVID itself, which is people who are still really, really fatigued, really breathless, can't return to work, have very low energy, and have symptoms which seem to be related to the acute COVID infection they had. Whether it was relatively mild at the beginning or whether it was severe, these symptoms are still possible. There's another group of patients which are just beginning. We don't quite know enough about it yet, but it's going to hit us, I think, which is a really big increase in things like diabetes. There was a study that came out which suggested that about 2% of people who've had COVID will go on to develop diabetes, which is, it's a huge increase when you think about the number of people who are getting COVID. And we also know that COVID seems to be really, really bad for your blood vessels in your heart and in your brain, and that there's that kind of real worry about what's lurking around the corner of all the ill people who've been made ill by COVID, not just having an acute illness which was dangerous when they had it, but actually may be dangerous in the long term. Sorry to sound so gloomy, but it's looking bad, and we're going to need more of people like me, but I don't know where they're coming from.
Yeah, and thank you very much. No, it is worrying. That is, we all look to our great Minister of Health to solve the problems. But like you say, workforce is a long-term problem. So thank you very much, Helen. Can I now come to clearly come to Zubaida. And Zubaida, you have through the pandemic, through Indie Sage and elsewhere, spoken eloquently about the impact and highlighted the impact of inequity on the differential impact of COVID, on whether in health service or elsewhere. Looking, and in your relatively new role as CEO in the Equality Trust, can you briefly sort of give some forward thinking about how we are to deal with inequity. Of course, the cynics would say, well, this is society. We live in an unequal society. You know, why should it just be COVID that we take account of when it comes to inequality? Why not everything else? But what do you think is a pragmatic but reasonable, achievable goal over the next year or two to actually sort of start to address some of these critical issues that become apparent during COVID?
Oh, there's quite a lot to pack in there, Deenan. Well, I think, if we learned anything in this pandemic, we did learn what the consequences of pre-existing inequalities means. And so to answer the cynics, yes, it's not just about health. Actually, health is highly correlated to where you live, the type of housing you live in, the type of job you do, how much you get paid, whether that job is insecure, whether you can choose between self-isolating or putting food on the table because you're not financially supported. But all of those links, all aspects of your life, is highly linked to your health status, to your life expectancy, to the difference, as we saw in this pandemic, between life and death. And I think that clearly tells us that going ahead, there is no magic bullet there's no single bullet or magic bullet to how we can solve health inequalities. But what we do know is that you can't just focus on one area. What we do know is that we need to address issues around people's housing, because we saw in the pandemic, and we continue to see, that overcrowding meant that people were much more exposed to this virus, meant that people couldn't self-isolate with this virus, and meant that the virus spread very quickly through different generations in overcrowded housing. So we've clearly got to do something about overcrowded housing. We've got to do something about low paid and insecure work. And this is really important because we saw what the consequences of that meant. The reason many Black and ethnic minority groups, Black and Asian groups, were overexposed to this virus was because they were forced to go out to work when the rest of us stayed at home. It was because of their poverty levels, because they were in low paid and insecure work, and because of that, they ended up on frontline jobs. And that meant they weren't protected. So we need to do something about that. We also need to do something, and this was one of the most scandalous aspects of the way this government managed this pandemic, which is in relation to how they financially supported those on low pay. We knew that sick pay, first of all, wasn't enough on, what was it, £95 something. We knew that sick pay wasn't enough. We knew that about 2 million people were not covered by sick pay because their income was too low. And yet those people had no real extra financial support. And even what the government then did do, saying, well, you can apply for £500, that was so difficult to access that hardly anyone accessed it. So we had millions of people that had to choose between self-isolating or putting food on the table. So there are all these aspects that, looking ahead, that we need to address. But the other things that we don't talk about, it wasn't just Black and ethnic minority groups that were hit hard. It was those in deprived areas. We know that they were 2 times more likely to be hospitalized and die with COVID. We also knew that they were less likely to take up the vaccine. So there was that real double whammy there. But we also know that those with learning disabilities in this pandemic were 8 times more likely to die with COVID. And that's shocking. That's absolutely shocking that we didn't do anything about that. So I think looking ahead, it really needs a cross-departmental government strategy to deal with health inequalities. And we need local strategies to be supported financially to deal with health inequalities.
Thank you very much. That's a really important contribution. Okay, the last three, I'll come to Steve, Anthony, and finally Christina, just to allow her time for recovery from her initial data dump. So Steve, and hopefully we're on track for maybe another 10 minutes maximum. So Steve, you've talked at length about how the virus is spreading and how it's evolving, and of course we could all hold our hands up and say, oh no, there's going to be another a variant, and of course we all believe there is going to be another variant, and it's never ending. What do you think is the longer term trajectory of this particular virus, and perhaps other viruses that are coming up? And how do you think, we should actually be dealing with that, maybe from a testing and surveillance sort of perspective?
Sure, thanks, Dean. Apologies, folks, I'm a bit croaky from a non-COVID upper respiratory tract infection. It's so hard to predict, but one thing that is pretty certain is that the literal scale of the pandemic that's still ongoing around the planet means that this huge change engine is going to continue to produce new versions of this virus, which will thrive when they are successful in bypassing the immunity that we develop either following infection or through vaccines, or other means as well. And we're seeing differences in the inherent transmissibility of these viruses and indeed in their ability to evade our antibodies. And the problem is that whilst people rightly say that coronaviruses aren't as inherently variable in terms of their molecular basis of their replication within a cell, within a person, they do seem very good at accumulating these mutations as a constellation of changes and as lineages, which is what we term these new variants of concern. And without getting a hold on the level of infection, of prevalence, this means that our vaccination programs, which will be the way through this eventually, in terms of reducing the effects of severe disease, this means that the immunity, particularly against infection, because antibodies will always naturally drift down over time, will continue to be challenged. And exposure is what drives us to have these surges that Christina so eloquently described at the start of the briefing. This is why we're not in a static situation. We did a session the other week on endemicity. We're nowhere near that. Our immunity isn't stable. The virus is dynamic. This means that we're going to either have to accept that we're going to see continuous infection amongst our population with the health problems that gives, or that we have to continue frequently boosting. And we have to say that we're in the dark on this. We've never had a vaccination program that's having to sort of rapidly be reviewed and restored and replenished with these emergency booster programs across the board. We're still not vaccinating children in schools properly. That much is clear. And of course, the major enemy that we have here is viral prevalence at the end of the day. This is what drives the challenges to our vaccine. This is what drives the huge incidences of long COVID that we're seeing. This is what's driving clinically vulnerable amongst our population to be sidelined once again whilst everyone's moving on. And what you also see is that those incidences that are less common, less frequent, such as children becoming severely unwell as a result of this virus infection, begin to creep up in real terms. And that is a major problem clinically for people like Helen, and it's a major problem for us as a nation, because it's a level of harm which we can do something about. And we've spoken countless times about what we can do: ventilation, vaccination. The Swiss cheese model of dealing with this virus still applies, in my view, because until this level of virus replication and evolution is under control through widespread vaccination across the planet, we're not going to be in a stable equilibrium with this virus. And ignoring it is not the same as living with it.
Brilliant. So we're not going back to normal. We need to really expect to have to change how we do things to take account of all of that. Thank you very much, Steve. Can I come to you, Anthony, as in effect one of the founders of Independent Sage, and you've spoken extensively about the inadequacies of the current sort of more formal scientific advisory structures within the UK. And IndySage, one of the reasons IndySage coming into being was precisely to address some of those issues. Where do you think that advisory set of structures needs to now move to for this next phase of the pandemic? Because as we've heard, SAGE is being stood down. A number of these committees are meeting less frequently. Chief Medical Officer, Chief Scientific Advisor seem a little bit more absent from the day-to-day engagement with COVID. What would you suggest, and what can we learn from elsewhere, Anthony?
Wow. Well, I think we're in not a great position. I'm not sure that we're any better than we were at the very beginning of this. You know, you would think that we would have learned lessons. I think the first problem was that we never had a proper pandemic management team with clear lines of leadership. I remember Sir Paul Nurse, after about 3 months, saying, who's in charge? Was it Matt Hancock? Was it, you know, the head of PHE? Was it the health service? Nobody really knew. So on that front, having a much broader based, multidisciplinary, equity conscious, BMA represented team, which looks at all aspects of from care to vaccination to social mobilization and the like, was needed and is still needed. And certainly when I was at WHO, that's what one always had for crisis teams for different outbreaks, with with, you know, everybody from all around the regions on screen, with lots of disciplines, logistics, communications, media policy, epidemiology, and the rest. I don't think we clearly had that in the pandemic management team, wherever that was. If you have a scientific advisory group, again, the WHO is that civil servants should not be on that because they're government employees. They can convene it and attend it, but actually you should have independent scientists who are prepared to thrash out. And we've seen actually in the media and on Twitter, a lot of debate going on, you know, and that's science. You know, there's not always agreement across a lot of things, and you have to have debates, and it's been very fertile in some ways. But, you know, our SAGE at the beginning was not independent. It wasn't really transparent until actually we kind of started, and then they did release minutes. There are a lot of very good people on SAGE, and in fact, much of the time we've agreed with most of the findings subsequently. I think there were mistakes early on, but they didn't have a single public health person on the panel early on who was independent. They didn't have an international person. You know, they should have had Martin McKee or Gabriel Scally on, or someone like that. We had a lot of modelers, and modeling is important, but it's, you know, early on, the key thing is to act fast, as Mike Ryan from WHO said, you know, have no regrets, find the virus, lock it down. The worst thing is not to take action. And we were slow. I think everyone, you know, the Health Select Committee report showed that we were slow to set up testing, tracing, and the like. So, I mean, the other big issue is to not forget that the economy and public health are completely linked, which is a point Martin made earlier. And we kept saying, oh no, well, we can't do too much of this public health intervention because it will affect the economy. And we ended up with a much worse economic hit than the Asian countries. None of them had a GDP decline of less than 1%. China, I think, was hit 0.9% in 2020. We had a staggering, the largest in our history. It was nearly 10% hit in 2020. The overall impact on our economy, well, we saw yesterday, we're paying for it now. And we're also paying for it in the future because we're seeing the food insecurity that's going to really, you know, crash across the world over the next year. And so, you know, dealing with pandemics is so important early on, and you have to invest in it properly, and you have to get governments to do that. And I'm afraid across the world, we're just not doing that. And I mean, I'll just finish with one little story, which I think I've told before, but that is that, you know, Dr. Tedros of the World Health Organization put out a call for $675 million, okay, in February 2020, just to try and help the poorest countries, because he didn't have any money, because WHO doesn't have. They have to continually ask. And I met him a month later and I asked him how the call was going. And he said, so far we've received $1.5 million from Ireland, because Mike Ryan was the head of the emergencies and came from Ireland. I mean, this is such a fiasco that if our global health defenses against something that's hit the world economy by 20-30 trillion dollars, and we spend, have to raise 1.5 billion in the first 6 weeks. I mean, it's pathetic. I'm not saying WHO is the only thing, but that is emblematic of the failure, I think, of us to look at economic defenses and public health defenses.
That's great. Thank you, Anthony. And of course, it would be great if Patrick Vallance picks up the phone to you, asks your advice on how to restructure scientific advisory systems in the UK. I suspect it won't happen, but nevertheless, it's really important. So last but not least, coming to Christina. And Christina, you and colleagues such as Kit and others have lit up Indie Sage and our engagement through not only describing data, but also I'd say more importantly, interpreting those data. And we are now a much more data literate society, both as we sort of continue through the pandemic, but also there'll be future health challenges that require that level of engagement. What's your sense of what do you think we've learned, and where do you think sort of dashboards explaining data in the way that you do, where does that play a role, and how should that be embedded in more substantive organizations than Indie Sage in future?
Well, I'm a bit less optimistic than you that everyone's become data literate. I think we've seen an explosion of data, and I think we've seen an appetite for data and for understanding data, and that is good to see. I think what we've also seen is that actually the kinds of things that I've been doing, that Kit's been doing, that other people have been doing, of interpreting it, are crucial. That you can't just stick out a bunch of graphs or tables and leave it at that. And that's because you need to understand the context, like one bit that never shows you the whole picture. You have to look at all of it. And it's really, really hard to keep up with, the different bits of research, the different dashboards, all the different things, the different nations, what's happening internationally. That's really difficult. And you can't expect people to all do it on their own. And so one of the things I actually think has been really lacking over the last 2 years is, Sage has been doing, well, when they were there, they did a lot of reports. They did a lot of really good reports, including, InspireM did a lot of their modeling, which informed policy, but they never came out and explained it to people. They would just put on a PDF on a website somewhere that it's not particularly accessible. It's not that readable. Like, it took me, especially for some of them, they're basically academic papers that you have to try and get your head around. And that left this vacuum for people to take the data that they wanted to hear and the interpretations they wanted to hear, including policymakers. And that's what I think has to change, that the next time, or now, because it's not over, now and going forward, you need to have that dedicated public communication. And it's not a press conference of Patrick Vallance showing 10 slides. That's not it. You need to do a lot more than that. You need to explain all of it, not just the bits that you actually want people to hear because it supports government policy. And I don't know how you do that. I don't know how you make it independent enough to be able to do that, because I do think that has been an issue. And I think there's also a big issue in the things that we're not measuring every day. So everyone's become kind of obsessed with a daily dashboard, and me too. And I've loved it, and I think they've done a great job. But the things that aren't on there, long COVID, deprivation, long-term impacts that we're just finding out about now, and like Helen's saying, is causing a big issue. Like, that has to be part of policy making, and it won't be as long as we're only obsessed with the short-term impacts of COVID. And it just seems like that's really short-sighted. If it is 2% of people with COVID getting new onset diabetes, that's massive. That has massive implications for every society. And there are other things that might be coming out. We've already seen there's an elevated risk of heart failure. A biobank study this week showed that there's an elevated mortality risk in all age groups after COVID for a year. These are big issues that haven't made it into policy making, and are partly informing why people think it's fine to live with these insanely high cases now. And until we rethink how data goes into policy and what we're not measuring and how that should go into policy, we're just going to keep making the same mistakes again. So I'm kind of not that hopeful, because I think long-term planning is not something we're very good at all.
Well, powerful words, Christina. And I must say, you've actually contributed hugely to what literacy there is growing, and thank you for that. So thank you all for being quite honest and but also looking to the future, and hopefully for our audience that's been a useful session. Back to you, Alice.
Thank you very much indeed, Dean, and that's been absolutely fascinating. And I had a chance to jump on the website as well and have a look at that new document, and I'd encourage everybody who's watching to do that as well. So that new document on basically the next steps, learning to live with COVID and what that actually means, is up there right now, and we're really interested in your views, so please do let us know what you think. That is a consultation document. So let's have some questions from press and public then, and we'll start with John Hebden, who joins us from BCB Radio. John, are you there?
Yes, hello Alice, thank you. So I'm trying to look for something positive in this very bad situation, what Christina's just called insanely high case numbers. Is there a silver lining in that levels of immunity caused by these high levels of infection will be very high as we go into the summer, just thus leading to, I suppose, a type of herd immunity, and therefore lower levels of infection will follow soon on the back of that, given the high levels of immunity?
Thank you very much, John. So Steve, would you like to start with that? Can we expect to see some herd immunity, given that we've got so many people suffering with COVID right now?
Well, to an extent, yes. But in reality, the fact that we're continuing to see surges on this scale speaks to the fact that, unfortunately, exposure and infection does not correlate necessarily to immunity. Now, the ONS brought out a report this week, which was actually really important. They've actually raised the threshold of the levels of antibodies that they're detecting in people to be protective from what it was, in recognition of the fact that, particularly for variants such as Omicron and so BA1 or 2, require that much higher and actually better trained immune response to be protected against. And that's why boosters and vaccines help by both raising the levels of antibodies and also their ability to hit the virus where it really hurts. Now, the problem is that some studies are showing that if you're infected with Omicron, it doesn't really leave much of a fingerprint. It's not giving you that protective response after infection. And another aspect is that in children as well, it seems as though when they do make a response, that seems to fade. And that's why, the numbers that Christina is saying, 10% day by day of whichever country are infected, we've had waves and waves of this. We've had antibody positivity since last summer in the high 90s, and that hasn't prevented these surges. And that's because we're not in a static situation. So yes, summer will help. Yes, these waves of infection will increase the resistance inherently in the population to disease, but vaccines really are the way forward. But it's the combination of exposure and immunity. You need to tip that balance back in our favor to make sure that we see cases going down. Otherwise, we could see what we saw last July with a plateau of cases, unfortunately.
Thank you very much, Stephen. And forgive me if I've missed this in the discussion, but I mean, are we looking at a situation where we're expecting to be annually boosted for COVID? I mean, given that we know that immunity wanes over time, what's going to happen next winter?
Well, it's important to discriminate the immunity from infection, which is mainly your antibodies, although antibodies do help you reduce disease as well, and that longer term protection against severe disease. Now, the problem is that that's not an all-in-one, and we make a bell-shaped curve type distribution response to vaccines and infection. So there will always be people who lose protection more quickly than others, but then there will also be people that make really, really good responses. Most of us are well protected by our vaccines. Unfortunately, with high levels of infection, that tail end of people that aren't responding well becomes a larger number in real terms. I haven't heard a good strategy about what the boosting program will be. I imagine they want to try and move it towards an influenza type program, but I think, as we've discussed on this many times, SARS-CoV-2 is not influenza, and it's not clear that that will work.
Zubaida, you wanted to come in as well.
Well, sort of just to follow up on what Steve was saying, which is especially around vaccines, what we need to understand is not only that you have vaccines that are waning, a situation where vaccines are waning, but also a situation where a large part of the population are either under-vaccinated or unvaccinated. So when it comes to primary school, the majority of primary school children are unvaccinated. So we've seen not only single infections, but reinfections. And at times we're looking at triple infections, during the last little period. And so you've got these kids, you've got under vaccination, unvaccination. And I wonder with them, because they'll be constantly playing catch up if we have a vaccine only approach, if that's sufficient. We've also got, of course, people who are immunocompromised. And we've got, as I said at the beginning, people who, because of their socioeconomic circumstances, because they're more likely to live in deprived areas and so on, who will be much more exposed to this virus, regardless of how much they're vaccinated. And I think that is the biggest concern. And that is the biggest, strongest argument for why we can't have a vaccine-only approach to this virus.
Thank you very much, Zubaida. Thank you for that question, John. And now we've got a question coming in from Graciela Almandral. Graciela, are you with us? Graciela joins us from La Sexta, the Spanish television news channel. What's your question?
Hello, thank you for taking my question into account. My question is, what do we really know about Delta Cron? Is it a new variant that has arisen as a recombination or not? Why I am asking this question? Because if you listen to the World Health Organization, they have recognized it and they are now tracking it. But for example, if you listen to the PAHO, which is the World Health Organization, but in Latin America, they say this is not a new variant. This is a kind of co-infection of two variants in the same person, but this is not a new variant. So is it? Is it not? Is a problem of recombination or not? Thank you very much.
Thank you very much, Graciela. Deenan, is this one for you? And then I'll come to you, Steve.
No, go to Steve directly for recombination expertise.
Okay.
Okay, thanks, Dina. Right, so the history of Delta Cron was that so the idea of a recombination is that literally the genetic material of the virus is spliced open and a new piece of genetic material from a different virus is inserted into there. Okay, so that's what we call a recombination event. For that to happen, you have to have had an individual that was infected with two different strains of the virus at any one time. They physically have to be present within that body. Okay, now whether or not that resultant virus is viable is another question entirely. A few months ago, or a couple of months ago, there was a story around so-called Delta Cron emerging in, I think it was Cyprus, and that turned out to probably be an artifact of the way that genomics is done in terms of how we sequence the viruses. However, there is a case now in France, and that has now, well, the case of this happening that has now spread and is spreading across the planet. And that is the Delta variant with the Omicron spike inside of it. That's been ratified by the Pasteur in Paris. So we know this is happening. We know it's viable. So it's a viable virus. It will spread. What remains to be seen is how well that virus will compete with standard Omicron that we have around at the moment now, in terms of how many people it will infect. And we also don't understand enough about how that will cause disease in people, whether it will be any different to Omicron or not. You would hope, by and large, that with vaccinations, you'll see the same pattern of people being mainly resistant to severe disease, but obviously those vulnerable people and the minority that don't respond well won't be. So it remains to be seen. There certainly aren't any signs of it becoming dominant anywhere as far as I know. So it's something to watch, something to be concerned about. And again, evidence that this virus is not static. It's in a dynamic flux and will continue to be so as long as we have a pandemic.
Thank you very much, Steve. So that was really clear. It definitely is a new hybrid virus, but we don't know how it's going to behave just yet. Anthony, I think you wanted to comment as well.
Just very quickly to add, 90% of people in low-income countries are not fully vaccinated. 90%. And this is after 15 months. The complete failure of the global community to get together to provide vaccines to the poorest countries. And people are very angry about it, I can tell you. I spoke to the head of WHO in Africa just last week, and she told me that, people are furious. And they're not getting access either to donated vaccines or to the capacity to make them themselves. So that means that, over 3 billion people in the world are going to just be infected and infected and infected. And that means for all of us a threat. I mean, we've gone from these huge surges in a largely unvaccinated world to now this kind of low-level reinfection type with surges and peaks with new variants coming, and there may be another one that's worse. And we're living with the virus in the UK means 50,000 deaths a year and maybe 700,000 hospital admissions. I mean, this is crazy. And unless we really tackle it as a world together, this is going to continue for as long as we can see at the moment, unless something magical happens in the next couple of years.
Thank you very much, Anthony. Thank you very much for that question, Graziella. And I want to squeeze in a couple of quick questions on my last session. We're going to overrun very slightly. So we've got a couple of questions from the public. Eleanor from Mansfield is joining us. Eleanor. Oh, I have to read it out. So do we know whether the original Omicron provides any protection against BA2 or the other way round, please? So if you were infected with the original Omicron, are you partially protected if you were to get BA2? Is this another one for you, Steve?
Where's Danny? Or Deenan, would you like it?
Well, I think you partially answered this, Steve, in an earlier response.
Yeah, so yes, you are to a point, absolutely, but not completely. These two viruses have some differences, particularly in one area of the spike protein against which we do make antibodies. So there is a lot of reinfection, but yes, you will get protection in terms of antibody responses between one and the other. There's less information around about two protecting against one, and of course, two protecting against one is less relevant because one is dying down. So yes, I think the best thing though is boosted vaccination is definitely preferable to prior infection, regardless of the circumstances.
Thank you, Steve. And another one from Louis Stowell, again to be read out. What are the testing plans to ensure that we pick up new variants and keep on top of numbers generally? Now the various programs are winding down. So what are we still doing? We must be doing sequencing to see if new variants are popping up in the UK. What is the testing program at the moment, Deenan?
Yeah, well, it's a great question because a lot of things are being wound down, and of course the genomic structure, which was called COVID Genomics UK, COG UK, was hugely successful when it was linked specifically to, if you remember back, the tier 1 and tier 2 testing structures, one being sort of NHS laboratories for hospitalized patients and the other being the lighthouse labs. And there was a flow of samples from the PCR tests into that genetic pipeline. But of course, much of this has been wound down. Lighthouse labs are no more. Fewer and fewer people are, if they test themselves positive by lateral flow tests, are not going and getting PCRs. We'll have to buy our lateral flow tests soon to be able to even get a diagnosis, let alone get a PCR. And so it's going to revert back to my senses, it'll revert back to a much more partial sampling, maybe of hospitalized patients, maybe linked to the sort of, there's a primary care influenza surveillance network that currently is in existence, but that's a very small number of samples that end up being sequenced, and therefore there's no doubt the quality of what we've seen and the rapidity with which we can respond to new variants, this is going to disappear. And I just finally, one of the things, in fact, in the document that's up on the website for consultation is asking how best can we start to build the existing COVID surveillance into our routine surveillance of other infections. But that doesn't mean downgrading it. That means enhancing it. But this moment in time, I fear that, under the auspices of the NHS, the test and trace budget is finished. We've got to actually sort of downgrade all of these things, that we will lose our ability to do that. And that will obviously have impacts on how people like Christina can warn us of new variants coming up.
Thank you very much. And I wondered if I could throw my own question at you just to finish off today, which is that you've put that consultation document out together. You've done this throughout the course of the pandemic, and you've engaged with the public. You've listened to public concerns via these briefings, but also via social media. Many of you very, very actively on social media. As we move into this new phase of the pandemic, do you think that there's been enough consultation with the public over what we are prepared as the great public of Great Britain, over what we are prepared to accommodate in terms of morbidity and mortality, in terms of the level of illness that we're likely to have in the future because of that, as we heard so eloquently from Helen, in terms of mortality? I mean, I think Boris Johnson said last summer that he was prepared to have 50,000 deaths a year. And I think that was probably an economic calculation. But has the public, has the UK public ever been asked if they are happy with that level of mortality? Christina?
No, we've not had this conversation, and it drives me mad. Basically, we've not had it. We just get told it. And not only have we not had it, like, to have that conversation, you have to accept that there is a downside to living with COVID in the way that we're trying to do. And the government has not acknowledged that there's a downside at all, despite the evidence that's in front of our eyes in terms of disruption to workplaces, to the education, to the NHS, hospital admissions, deaths. Despite that, we've never actually looked at it and said, okay, are we prepared to live with 10,000, 20,000, 30,000 extra deaths, lower life expectancy, increased health inequalities, more sickness, more diabetes, more heart disease? We've not had that conversation at all, because we haven't even acknowledged that that's the current consequences of what we're doing. And it does feel a bit like we're in this kind of emperor's new clothes situation where no one wants to say it. No one wants to say, guys, there's a lot of sickness going around. It's a cold. That's the only thing people come back with, when it self-evidently is not a cold. And I kind of like, we have to move beyond that. We absolutely have to. And maybe it won't be this wave. Maybe it'll be the next wave. Maybe it'll be the wave after that. Maybe in 5 years' time, people will say, guys, maybe we should do something about COVID. But I don't know. I don't know what to say other than that.
Martin, you wanted to come in as well.
Yeah, I think the biggest failure throughout all of this has been the government's refusal to engage with the British public to have these discussions. And exactly as Christina said, it just makes me really angry, because it's not just the level of deaths, that if we're going to have wave after wave infecting children, then it's just going to be a lottery as to whether any particular year group gets to their GCSEs and A levels at the trough or the peak of a wave. And if they do have their exams coinciding with a wave of COVID, then that group is going to be disadvantaged throughout all of their lives. It's going to be a lottery. And then it's just how you actually manage it. Now, many people have suffered vastly more than, I don't want to personalize this too much, because I've been really careful. I haven't had a COVID up until now. I have it now. But otherwise, I would be at a project meeting in Paris today. I would be going to another meeting in the Middle East, flying out on Sunday. I'm not doing either of those. Now, these are trivial compared to most people's, the way most people have been affected, and I fully accept that. But the disruption that this will cause to commerce, to trade, to educational exchanges, to all sorts of other things, when you're really hesitant to plan ahead, it's the uncertainty that all of this introduces. I just don't know how we go ahead living with that degree of uncertainty, disruption, and just the risk of chance that you happen to be planning something, weddings, whatever, with all of this, it's just beyond me.
Thank you, Martin. Helen, I think you wanted a word as well, and then Steve.
Yeah, I mean, I share everybody else's frustration. Two things, I think. One really unpleasant strand that has gone through this has been a kind of emphasis on who's getting ill, actually, and who's dying. It's only people who were vulnerable anyway or had underlying conditions. And actually, there's a kind of rhetoric in there which I don't think reflects what the British people really feel. At least I hope it doesn't, which is that somehow these deaths are less important. And I think we need to have real conversations about valuing every life and actually being a civilized country and valuing the lives. I mean, those statistics about people with learning disabilities are truly shocking, that those lives have not been valued. And I think we need to be having those conversations out loud. But I also feel that just the bare facts of who's been ill and who is dying and what the long-term consequences are haven't been made plain. And I do think that we've heard so little from our chief medical officers and our chief scientific officers. It just hasn't been made clear. It almost seems as if there's a kind of a decision deliberately not to let people know how bad it is. So I think the communication has been, it looks like deliberately poor, I don't know, but it has been very, very poor, which has not let given the British people any chance to have a say, to have an input, to voice their opinions, because they don't know what's going on. What they're told is it's all gone. It's all gone. Let's pretend it's not here anymore. It's not true, but people don't know that. So I feel it's going to be a huge wake-up call when this burden of ill health continues and all the other things that COVID brings in its wake. Yeah, I'll stop. I could go on.
Thank you, Helen. Steve.
I think I might pick up where Helen left off. Just a related point, really. Just, the people that are clinically vulnerable, the irony about this whole idea of letting this virus run rip, of relying on just vaccines, is that these are the people that are least well protected by these strategies. These are the people that have shielded, many of them since 2020. They've taken themselves out of the horrendous statistics to a great extent that we see day by day because they have isolated themselves from society. It's important to recognize this is actually a long-standing issue with people with chronic health conditions and disabilities that we've struggled to recognize throughout the whole of recent history in terms of health, but it's been exacerbated by the pandemic. And it's very easy to move ahead based on the percentages of people. And it's this whole adage of percentages of a very large number still being a very large number. And I think until we can make reasonable accommodation for these people who don't expect a risk-free existence, of course they don't, but reasonable accommodation by making our air safe, by making sure we all vaccinate and by making sure we take the right precautions like masking and things. That is a fair society. That's an equal society. That's how we live with this virus. And at the moment, that really is not happening.
Thank you very much, Steve. I think I am going to have to wrap it up there. So that is all we have time for. Thank you to everybody who's watching. Thank you to our incredible scientists and members of the press who've joined us today and members of the public who sent in their questions and continues to support us. The document that Dean presented on long-term strategy is up on the website, as I've mentioned. It is a work in progress. It is a collaborative document. And we've opened up a window of 2 weeks where we welcome suggestions from all of you on what more could be done on that long-term strategy. And you'll find details of how to provide those suggestions on the website and also on Twitter. We can't wait to hear from you. As Martin mentioned at the start, this is my last session as the regular chair of Independence Age Friday briefings. I've absolutely loved working with this incredible group of scientists. It's been a very positive movement over the course of the pandemic, and the citizens group who make these live sessions possible. I'm constantly in awe of the way that Independence Age scientists work so tirelessly to bring science to the public in a time of crisis when there's been so much uncertainty, so much anxiety, and so much disinformation. Our most powerful tool to combat all of that is science. Science helps us arm ourselves in the most effective way, helping to save lives and lessen the impact of the pandemic. But these sessions have also been about listening to the public and understanding people's concerns, and that remains very important. Independence Age will continue with all that work, and I will continue to support them wherever I can. And I hope that sometime in the future, they'll have me back to chair a briefing as well. So I'll say goodbye for now, but our scientists will be back here next week to answer your questions. Same time, same place. Stay safe and keep well.
Thank you, Alice.